So if you see the rapid revision of the gastroenterology, mainly I have incorporated the hepatology part, right, and as well as that is cirrhosis of liver and its complications. And next important thing which I have incorporated is the viral hepatitis, that is your hepatitis B and hepatitis C, which is very important for your exams. Okay, now let us start with the GIT rapid revision, and the PDF of this has already been posted on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can just go through that. Okay, right. So if you see the first clinical scenario, by seeing the image itself, you will be able to answer this question. So what exactly is this suggestive of? This is suggestive of the hepatic encephalopathy, right, where there is the asterixis. But this particular asterixis is not just seen only in case of hepatic encephalopathy. There are many other conditions where you can have the presence of the asterixis. Okay, now you see this question: a 73-year-old man with a history of alcoholism and hepatitis C presents with lethargy and hypersomnia. He has been sleeping all the day and not taking any of his medication. On examination, the patient has ascites, palmar edema, and spider telangiectasia. He also has the flapping motions of his hand when dorsiflex. Laboratory results revealed a normal ammonia levels. This point is very important to me. Normal ammonia levels. See, whenever there is hepatic encephalopathy, like what do we suspect? We suspect that ammonia levels are very much elevated. But in this patient, normal ammonia levels are there. Now, what is the likely diagnosis? What is the best initial therapy? What is the best initial therapy to reduce the recurrences or improve the quality of life? Okay. Now, so if you see the first important thing, that is the toxic substances. What exactly is that? Alcoholism is there, hepatitis is there, very much suggests you have hepatic encephalopathy. But you take these toxic substances. Definitely, ammonia is one of the most important toxic substance that will be responsible for development of hepatic encephalopathy. But apart from ammonia, you have many other substances like gamma amino butyric acid, that is your GABA. Next, the other one is the mercaptans. Right, the other one is the mercaptans derived from the methionine. Then short chain fatty acids, right, short chain fatty acids, then amino acids, then phenol, and we have one more, that is octopamine. So these are the toxic substances which are responsible for the development of your hepatic encephalopathy. So what exactly is the earliest manifestation in hepatic encephalopathy? The earliest manifestation in hepatic encephalopathy is reversal of sleep rhythm, right, reversal of the sleep rhythm. That means these individuals, they'll have excessive sleep in the morning and reduced sleep in the late night or in the night. So that is the earliest clinical manifestation. Then what is the earliest examination finding? Remember, the earliest examination finding is not your asterixis. It is not your asterixis. The earliest examination finding is a, okay, I'll just show you this image. Yes, right. So the earliest examination finding is constructional apraxia, right? Constructional apraxia. What does that mean? See, you have to draw a simple image. This is you, and you ask the patient to copy the same thing, but he will not be able to do that. That is what is called constructional apraxia. Now, apart next to this constructional apraxia, what are the other examination findings that you can have is this asterixis. Now, this asterixis is not just seen only in hepatic encephalopathy. The other conditions where you can have this asterixis is, you can also see in case of carbon dioxide narcosis. You can also see this in case of uremic encephalopathy. These are the differential diagnosis for your asterixis. Okay. So next is like, yeah, earliest examination finding is what? Constructional apraxia. Now, what do you think is the most relevant investigation in these patients? See, it is not your serum ammonia levels. Why? Because the serum ammonia levels may appear normal, right? It may be normal. Why? Because there are many other toxins which can cause the hepatic encephalopathy. There are many other toxins which can cause the hepatic encephalopathy. So that is the reason why the most relevant investigation we don't take into the serum ammonia levels. The most relevant investigation what we take is the EEG, that is electroencephalograph. Right, that is electroencephalograph. Now what will this electroencephalograph shows? The electroencephalograph, it will show you the triphasic wave pattern, right? So you have the stages in case of the EEG. So you have stage 4. In stage 4, you have the classical triphasic wave pattern. So this triphasic wave pattern is very, very important in the EEG. Okay, so this is the EEG. So in stage 4, you get this triphasic wave pattern. Okay, and that will be the relevant investigation in these patients with the hepatic encephalopathy. Now, what do you think is the best initial treatment in these patients? The best initial treatment in these patients is you need to give lactulose, right? You need to give lactulose. Now, what is the advantage of giving this lactulose? The lactulose is that which will convert ammonia to ammonium, and ammonium is being excreted out. Okay, so the best initial therapy will be lactulose. Okay, this will convert ammonia to ammonium, right? And what are the other treatment options? The other treatment options that includes rifaximin. What is the purpose of giving this rifaximin, which is an antibiotic? See, rifaximin, it will act as a bacteriostatic agent. Why? Because when you give this rifaximin, it will kill the gut bacteria. Why you want to kill the gut bacteria? Because if there is presence of the gut bacteria, they can cause the fermentation of the food within the intestine, causing increase in the ammonia levels. So we don't want the gut bacteria for a while, so for which you need to give rifaximin. And not only that, the constipation is also a very important risk factor for the development of precipitation of the hepatic encephalopathy. So you also need to give enema to these patients. And next thing is, these patients with hepatic encephalopathy, when liver is gone, there is high chance of bleeding tendencies. So you need to supplement fresh frozen plasma, FFP. And once liver is failed, there is chance of hypoglycemia. So you need to give 10% glucose whenever the individual develops hypoglycemia, right? And another important hepatoprotective agent is LOLA. What is this LOLA? That is L-ornithine, L-arginine, right? L-ornithine, L-arginine. So that is what is your LOLA, which is the hepatoprotective agent. Now we have a form of dialysis called as the liver dialysis. What is this particular liver dialysis is? That is the MARS, M-A-R-S. What is this MARS? That is molecular absorbent reabsorbent system, right? Molecular absorbent reabsorbent system, by which you can take out the toxic substances which have been produced. So this is about the treatment in case of the hepatic encephalopathy. And one question that is being asked previously related to your hepatic encephalopathy is about the precipitating factors. Which of the following is not the precipitating factor for hepatic encephalopathy in patients with the chronic liver disease? Hypokalemia, hyponatremia, hypoxia, metabolic acidosis. Please remember, metabolic acidosis will not cause your precipitation of the hepatic encephalopathy. It is your metabolic alkalosis which can precipitate the development of the hepatic encephalopathy. And you have many other precipitating factors. What are the many other precipitating factors? That is the gastrointestinal bleeding, then excessive dietary intake of protein, then constipation, right? Then constipation. Next, azotemia, right? Next is the azotemia. So azotemia is that where there is increase in urea and creatinine, but there is no clinical manifestation. Next, the other conditions are the hypokalemia can also precipitate the development of hepatic encephalopathy. Next, metabolic alkalosis can also precipitate the development of hepatic encephalopathy. Hypoxia can also precipitate. Then hyponatremia can also precipitate the development of hepatic encephalopathy. So these are some of the important points related to the hepatic encephalopathy. So you need to know the treatment. So what is the immediate treatment that you can give is the lactulose. Okay, what this lactulose will do? It will act as an ammonia binder. That means it will convert the ammonia to ammonium, and ammonium is being excreted out. Okay, and earliest sign, that is the alteration of the sleep wakefulness cycle. And what is the earliest symptom? Earliest sign will be the constructional apraxia, and these patients, they will also have aphasia that is called anomic aphasia. Anomic aphasia is like difficulty in naming the object, right? Difficulty in naming the object. So this is, and what is the reliable investigation? That will be EEG, that will be showing the triphasic wave pattern in stage 4, right? Triphasic wave pattern in stage 4. Okay, right. So once we are done with this topic of the hepatic encephalopathy, we'll move on to the next important topic in the GIT. Right. So what do you think is the answer here? The same thing. Symmetric high voltage triphasic slow wave pattern in EEG is seen in which condition? It is seen in patients with the hepatic encephalopathy. Okay. Right. This is one of your PYQ. Right. Now this is a very, very important clinical scenario. So the clinical scenario is a 47-year-old man with chronic alcoholism, presents with abdominal pain and fever, right? Presents with abdominal pain and as well as the fever. And he has multiple admissions for variceal bleed and ascites requiring large volume paracentesis, right? So multiple times he has undergone large volume paracentesis. The pain is diffused and has been getting worse since yesterday, right? Pain in the abdomen. He also has fever, chills and rigors. On examination, he has diffuse tenderness over the abdomen with shifting dullness and fluid wave. So what is the most likely organism which is responsible for this clinical scenario? E. coli, staph, Salmonella typhi, the Legionella. So what exactly is the diagnosis? First of all, the diagnosis here is the spontaneous bacterial peritonitis. And what would be the cause for that SBP? That is because of the repeated paracentesis what you are doing for the ascites what the patient is developing. And the most common causative organism for the development of spontaneous bacterial peritonitis will be the Escherichia coli. So this Escherichia coli, it is a gram-negative organism. Next to this Escherichia coli, the another important gram-negative organism will be the Klebsiella pneumonia. Next is, we also have gram-positive organisms. These gram-positive organisms will be the strep pneumonia, right? The gram-positive organism will be the strep pneumonia, right? So these are the organisms which are responsible for the development of the spontaneous bacterial peritonitis. Now, in order to diagnose, so most common organism is what? E. coli. Right? Now, the clinical features will be fever and as well as abdominal pain. Now, what is the accurate diagnostic test? The accurate diagnostic test is paracentesis, right? Paracentesis. So, in that paracentesis, if you do the levels of your WBC, the level of the WBC will be more than 500 cells per cubic millimeter, right? Or if you take only polymorphs, that is neutrophils. So if you take the polymorphonuclear leukocytes, that will be more than 250 cells per cubic millimeter. And even the protein content will be increased. The protein content of 1 gram can also be there. Okay, right. So that is what is the, okay, the accurate diagnostic test is what? That is paracentesis, where you need to check for the WBC and as well as polymorphonuclear leukocytes. Now, what is the antibiotic therapy that you need to give? You need to give the drug of choice as the third generation cephalosporin. And this third generation cephalosporin, either you need to give ceftriaxone or the other important drug will be cefotaxime, right? Ceftriaxone or cefotaxime. Okay. Now, if the patient develops the liver failure, right? If the patient develops the liver failure, see, in patients with spontaneous bacterial peritonitis in the setting of acute or chronic liver failure, the treatment should be done with meropenem. Here, we don't give ceftriaxone. What we give is meropenem, right? What we give is meropenem and daptomycin is being recommended. Meropenem and daptomycin is being recommended. So that is about your SBP, spontaneous bacterial peritonitis. And one of the very important area where frequently questions have been asked is on the topic of the assessment of liver severity. That is MELD score. Many times question asked, what is DF score and what is this child pug score? See, what they will ask you is the parameters or the variables which are included in your score, right? So, which among the following is not the variable or clinical parameter for MELD score? Which among that is not the part of your child pug score? What is the requirement of calculation of the DF score? All that we will discuss now. So, now coming to the MELD score. So, what exactly is your MELD score? That is model for end stage liver disease. That is what is your MELD score. Now, what are the parameters which are included in this is, that is the serum bilirubin, serum creatinine and as well as the international normalized ratio for prothrombin time to predict the 3-month survival. So these are the parameters which are included in your MELD score. So to confuse you, and one more, so to confuse you, what they will add in your options is albumin. So there is very high chance that we get tempted to albumin because we know that albumin is synthesized in the liver. So we may assume that because there is like liver injury, so the albumin levels may be reduced and that might be the parameter of your MELD. No, it is not the part of your MELD score. Now, this MELD score will assess the severity of the or mortality of the patients with the cirrhosis of liver. That is, so if the MELD score is like 40 or more, then the chance of mortality is 71.3%. And if MELD score is 30 to 39, mortality is 52.6. And if MELD score is less than 9, the mortality is 1.9%. So, and if suppose when you calculate the MELD score and the MELD score is like more than 14, he is the candidate who has to undergo liver transplantation. That is orthoptic liver transplantation. This particular patient has to undergo if the MELD score is more than 14. Okay, and in orthoptic liver transplantation, HLA matching is not mandatory. HLA matching is not mandatory. Okay, that is about your MELD score. Next one is your DF score, that is discriminant function score. Now, what are the parameters which are there in your discriminant function score is number one, serum bilirubin. Next is the international normalized ratio. And when you calculate this DF score, that is discriminant function score, if the score is like more than 32, first of all, in which scenario we calculate this DF score? We calculate this DF score in patients with alcoholic hepatitis, right? In order to assess the severity of alcoholic hepatitis. In order to assess the severity of the alcoholic hepatitis, we calculate this discriminant function score. Okay. Now, if this discriminant function score is like more than 32, it is an indication that you need to give steroids. It is an indication that you need to give steroids or you need to give pentoxifillin. Right? You need to give pentoxifillin. So that is what is your DF score, discriminant function score. Okay, right. And the next important score is the child pug score. The next important score is the child pug score. Now, if you take this child pug score, why is it being calculated? Even this also is calculated for assessment of severity in cirrhosis of liver. See, DF score in alcoholic hepatitis, MELD score, even this also in cirrhosis. So both of these are in the cirrhosis. Now you take child pulse score. What are the parameters which are included in the child pulse score? So the parameters which are included in the child pulse score is bilirubin, albumin, ascites, asterixis and INR. And if the score is like more than or equal to 7, he is a candidate who require the liver transplantation. He is a candidate who require liver transplantation. So this is about your the scoring systems for assessment of the severity of liver disease, that is cirrhosis and as well as the alcoholic hepatitis. Okay, right. So next important topic in the liver that you need to know is, you see this question. A 49-year-old alcoholic man presents with hematemesis that began 2 hours ago. He was intubated for airway protection. His past medical history, right, because he came in the altered sensorium and he had like severe hematemesis and he was intubated for airway protection. His past medical history is significant for hepatitis C infection that has not been treated. He consumes 1 bottle of whiskey a day and he is tachycardic of heart rate of 140 per minute with a blood pressure of 99/68 millimeters of mercury. Dried blood is seen in the oral cavity and palmar erythema is present, which is all suggestive of your liver cell failure. Telangiectasia are seen over the thorax, which are nothing but your spider nevi. That is due to increase in your estrogen level in cirrhosis of liver. AST and ALT shows 100:56, elevated. Prothrombin time is like 24, that is also elevated. Hemoglobin 6 grams per deciliter. What is the next best step in the management of this patient? IV fluids and blood products, octreotide, endoscopic band ligation, tips. So, what the question is very clear. What is the next best management? So, what you have to understand here is, what exactly is this clinical scenario suggestive of? This clinical scenario is suggestive of the esophageal varices which has been ruptured, right? Esophageal varices which have been ruptured, and because of which the individual is having hematemesis. How can you tell that the patient that developed esophageal varices, he is having a significant hepatitis C infection? And the other important point is, he is a chronic alcoholic. So he has developed cirrhosis of liver, and secondary to cirrhosis of liver, the patient has developed portal hypertension, and secondary to portal hypertension, the patient has developed what? The esophageal varices which has ruptured, causing hematemesis. Now, whenever the patient presents to you in this format, the first best management is the IV fluids and blood products. It is not your octreotide, right? It is not your octreotide. So you have to ensure that the blood pressure of the individual is being maintained. So IV fluids and the blood products are the first best important method, first best management. So what is the diagnosis in this clinical scenario? That is acute GI bleed secondary to rupture of the varices, right? Secondary to the rupture of varices. Now, what is the next best step? What is the best initial therapy? What is the most appropriate therapy? How to control the bleeding? And what exactly will be the discharge advice? So this patient actually had developed portal hypertension. Now to call it as portal hypertension, how much should be the portal venous pressure? So if you take the portal venous pressure, right, normal portal venous pressure will be 5 to 10 millimeters of mercury. That will be the normal portal venous pressure. But to call it as portal hypertension, right, the portal venous pressure should be more than 10 millimeters of mercury. Right, portal venous pressure should be more than 10 millimeters of mercury. Okay, now the point is this patient definitely developed portal hypertension. Now what are the other manifestation of the portal hypertension? One is your esophageal varices, the other one is surrounding the umbilicus, like you have that starry appearance which is called as the caput medusae. So caput medusae is nothing but dilated veins surrounding the umbilicus. And next important feature of your portal hypertension is the rectal hemorrhoids. Why is that rectal hemorrhoids? Because this portal vein, it has anastomosis with the rectal veins. So when the portal venous pressure is increased, even the rectal veins, they get enlarged. So thereby you have the development of rectal hemorrhoids. And what exactly is the investigation of choice in patients with the portal hypertension? Investigation of choice in portal hypertension will be the ultrasonography. That is Doppler ultrasonography should be done. But what is the reliable sign? Right? What is the reliable sign of the portal hypertension? The reliable sign of portal hypertension will be splenomegaly. Splenomegaly is the reliable sign for diagnosis of the portal hypertension, right? Now, what is the next best step in this particular patient who is undergoing bleeding? So, immediate resuscitation, right? Immediate resuscitation with IV fluids and blood products, that is, the fresh frozen plasma should be given, right? Why? Because the patient is unstable. He is hemodynamically unstable. Now, what do you think will be the best initial therapy once the individual is being stabilized? Once the individual is being stabilized by giving your IV fluids, then you need to give a somatostatin analogs, and that somatostatin analogs that you can give is the octreotide. You need to give is octreotide. Okay. Now, what is the other options? Next to your octreotide, the other options that you have is the terlipressin. The other options that you have is the terlipressin. Okay, terlipressin. Okay, now but if suppose what has been given in your CMDT 2022 is that between this terlipressin as well as octreotide, in countries where there is terlipressin being available, terlipressin is being preferred over the octreotide, right? Terlipressin is being preferred over the octreotide. And where is this reference from? This particular reference is from CMDT 2022. Right, so previously, like what all we were discussing was octreotide as a drug of choice, but CMDT 2022 says that terlipressin is maybe preferred to octreotide for the treatment of bleeding related to the portal hypertension. Okay, right. Next is the most appropriate therapy. Best initial therapy will be this. Most appropriate therapy will be esophageal variceal ligation or esophageal band ligation. That means it is nothing but your endoscopic band ligation. So endoscopic band ligation, in which the bands are placed over the bleeding veins to cause the tamponade effect, right? To cause this tamponade effect. Now, if the bleeding cannot be controlled, in case the bleeding cannot be controlled, then in such case you need to do a balloon tamponade, and this particular balloon tamponade is being done with Sengstaken Blackmore tube. Right, with the help of Sengstaken Blackmore tube, the bleeding can be controlled. Right. So how to control the bleeding? That is by balloon tamponade. Right. Then what is the discharge advice? See, discharge advice is that you have to ensure that the portal venous pressure is, right, the portal venous pressure is less than 10 millimeters of mercury. So for that, the drug which will reduce the portal venous pressure will be a non-specific beta blocker, and that non-specific beta blocker that we can give is propranolol, or the other important drug will be nadolol. right? The other important drug will be nadolol. Okay, so that is about your treatment for portal hypertension causing the esophageal variceal bleeding. And the another important treatment option, if the individual is having recurrence, then you can do what is called as the tips, right? So what exactly is your tips? The tips is nothing but transjugular intrahepatic portosystemic shunt. That means what you will do here, you will connect the branch of the portal vein to the branch of the hepatic vein, right? You will connect the branch of the portal vein to the hepatic vein, okay? And thereby, what is that you are doing? You are directly connecting the portal vein to the hepatic vein and making the portal venous blood directly entering into the hepatic vein, not entering into your liver, right? Not entering into your liver. So thereby, your portal venous pressure can be reduced because the portal venous blood will enter into hepatic vein and from there it will enter into the inferior vena cava, right? So that is about your tips, that is transjugular intrahepatic portosystemic shunt. Now, the next important thing in the GAT that you need to know is about the ascites, right? Next is about the ascites. Now, what is the criteria or when is that we use the terminology called abdominal compartment syndrome, right? What should be the abdominal pressure to call it as abdominal compartment syndrome? See, in case of the abdominal compartment syndrome, the individual can develop wet gangrene, right? Why there is development of your abdominal compartment syndrome in patients with cirrhosis of liver? That is because of ascites. And if the quantity of the fluid which is being accumulated in the peritoneal cavity is like huge, then in such case the fluid can compress, right? The fluid can compress the circulation of the blood to the visceral organs, right? And thereby, once the circulation of the blood to the visceral organs is being reduced, the individual can develop wet gangrene. This is an emergency now. So, what is the criteria? So, to call it as abdominal compartment syndrome, the pressure should be around 20 millimeters of mercury. The pressure should be around 20 millimeters of mercury to call it as abdominal compartment syndrome. Now, the very important point is, what should be the quantity of the fluid? Let me discuss this entire component of the ascites. What should be the quantity of the fluid to call it as ascites? When the quantity of the fluid which is accumulated in the peritoneal cavity is like more than 25 ml, we call it as ascites. Now, USG abdomen can detect the ascitic fluid up to 100 ml, right? USG abdomen can detect the ascitic fluid up to the 100 ml. And the Puddle sign, right? This is an important image based question. This is your Puddle sign. So Puddle sign can detect the quantity of the fluid up to 120 ml, right? The quantity of the fluid up to 120 ml. And this should be the position of the patient whenever you are eliciting the Puddle sign, where the fluid will get accumulated in the central part of the abdomen and where you will get the dull note in the central part of the abdomen, and in the flanks you get the tympanic note. So that is what is your Puddle sign. The next important is, so Puddle sign will be positive when the quantity of the fluid is around 120 ml. Next important is the shifting dullness. So what should be the quantity of the fluid for you to get the shifting dullness? The quantity of the fluid should be around 500 ml to develop the shifting dullness. That is simple. You shift the patient on one side, the fluid will be shifted from one flank to the other flank. So thereby you get the tympanic note on the opposite side and you get the dull note on the side where the individual has been slept. Okay, right. So that is your shifting dullness. Next is the fluid thrill. So when will the fluid thrill will be positive? The fluid thrill will be positive when the quantity of the fluid is around 1 to 1.5 liters. Right, when the quantity of the fluid is around 1 to 1.5 liters, that is the point when the fluid thrill will be positive. So these are some of the important points, like when, so shifting dullness, like 500 ml fluid should be there. The fluid thrill, you will have, the fluid should be around 1 to 1.5 liters. Okay, next is, when do you call the terminology called as intra-abdominal hypertension, right? Intra-abdominal hypertension, to call this, the intra-abdominal pressure should be more than 12 millimeters of mercury, right? And compartment syndrome, when will you call compartment syndrome? Compartment syndrome, the pressure should be more than or equal to 20 millimeters of mercury. And in this compartment syndrome, there can be kinking of the blood vessels supplying to the visceral organs, and thereby there can be development of wet gangrene, right? Next, tense ascites. When do we use the terminology called tense ascites? When the quantity of the fluid in the abdomen, in the peritoneal cavity is huge, where the fluid thrill is also absent. The quantity of the fluid is like more than 1.5 liter. The fluid thrill is absent, right? The fluid thrill is absent. Why? Because the fluid which is accumulated in the peritoneal cavity is like jam packed. That is causing the tense ascites. That is the reason why the fluid thrill will be absent. And in these patients with this ascites, how will be the umbilicus? The umbilicus is like ballooned out. The umbilicus is like ballooned out. So this is about your the ascites story. And next is about the SAG. Right? Next is about the SAG. That is serum albumin ascitic gradient. Right? So if the SAG is like more than 1.1 on fluid analysis, that tells you that the patient is having the portal hypertension causing ascites. And if the SAG is like less than 1.1, that means there is no portal hypertension, but there is development of ascites. So this is the importance of your SAG. More than 1.1, it is secondary to portal hypertension. Less than 1.1, it is not portal hypertension, but some other causes causing this ascites. Okay, so this is about the story related to the ascites component. Now then we have two more syndromes that you need to know in the cirrhosis of liver, that is hepatopulmonary syndrome and hepatorenal syndrome. Now you take this question on the hepatorenal syndrome. Okay, so you see this, which of the following should be avoided in case of the hepatorenal syndrome? So octreotide, terlipressin, diuretics, and as well as the norepinephrine. So first of all, what exactly is your hepatorenal syndrome? It is the complication which is seen in 10% of patients with advanced cirrhosis and as well as the ascites. And in these patients with the hepatorenal syndrome, there is renal failure, right? There is renal failure with normal tubular function, right? There is renal failure, right? What is the criteria is that there is development of renal failure with normal tubular function of the kidney. And these patients' kidney, if you do histology, histologically these kidneys are absolutely normal, right? And the renal failure, whatever it is being developed, it is the functional renal failure. It is a functional renal failure. And the pathogenesis for the development of this hepatorenal syndrome is the splanchnic vasodilatation that occurs in severe stages of cirrhosis of liver. Splanchnic vasodilatation that causes a reduction in the effective arterial blood volume, and because of decrease in the effective arterial blood volume, there is decreased mean arterial pressure, and thereby there can be decreased renal perfusion. So it is like completely the functional failure. Okay, and what are the precipitating factors for the development of hepatorenal syndrome? That is gastrointestinal bleeding, then sepsis can cause hepatorenal syndrome, then even diuretic therapy can cause the hepatorenal syndrome. That is the reason why diuretics are not given in these patients with the hepatorenal syndrome. And the another important precipitating factor is aggressive paracentesis, right? Aggressive paracentesis. Okay, next, then next important thing is the criteria. The criteria to call it as the hepatorenal syndrome. See, it is characterized by the azotemia, right? So what do you mean by the word azotemia? So azotemia means that there is increase in your serum creatinine. And how much should be that increase in serum creatinine? Increase in serum creatinine should be more than 0.3 milligrams per deciliter within 48 hours. Right? So within 48 hours, there should be increase in serum creatinine greater than 0.3 milligrams per deciliter. So that is one of the criteria to call it as the hepatorenal syndrome. And the next important is, to call it as hepatorenal syndrome, the patient should not be on any of the nephrotoxic drug, right? There should be absence of nephrotoxic drug intake, and there should be absence of structural kidney injury. There should be absence of shock. Then only we use the word the hepatorenal syndrome. And this hepatorenal syndrome, the clinical manifestations will be in the form of the low urine output. Low urine output. And once there is low urine output, the individual will develop what is called dilutional hyponatremia, right? Next, the other point is the types. We have two types of hepatorenal syndrome, type 1 and as well as type 2. See, type 1 hepatorenal syndrome is that where there is acute kidney injury. So acute kidney injury, which is formerly type 1 hepatorenal syndrome, in this there is doubling, right? In this there is doubling of serum creatinine to a level greater than 2.5 milligrams per deciliter. So the creatinine level will be more than 2.5 milligrams per deciliter. So there is doubling of the serum creatinine level, or there is decrease in the creatinine clearance, right? Whereas hepatorenal syndrome type 2, that will be chronic renal failure. That will be your chronic kidney injury. Okay, that is what is your hepatorenal syndrome type 2. Here, hepatorenal syndrome type 2, it is slow and it is progressive. Whereas hepatorenal syndrome type 1, that will be the acute kidney injury. So that is the reason why hepatorenal syndrome type 1, it has the worst prognosis than compared to that of the hepatorenal syndrome type 2. So what is the treatment that you have to give in this patient is, you need to give intravenous terlipressin. You need to give intravenous terlipressin. So this terlipressin, this is like approved for the treatment of hepatorenal syndrome, and the other drugs are, you can give norepinephrine or you can give midodrine, right? You can also give midodrine. So that is the treatment for your hepatorenal syndrome. But what is the ultimate treatment if these individuals develop hepatorenal syndrome recurrently? The ultimate treatment will be TIPS, that is transjugular intrahepatic portosystemic shunt. So that is about your hepatorenal syndrome, which is one of the very, very important complication in severe forms of the cirrhosis of liver. Okay, and the other option apart from the TIPS will be liver transplantation. That is also the another important option which is being available. Okay, that is hepatic or liver transplantation. Okay, so with this we are done with the topic of the hepatorenal syndrome. Next is the hepatopulmonary syndrome. Okay, so hepatopulmonary syndrome is that where through small communications within the diaphragm, the fluid from the peritoneal cavity can enter into the pleural space, causing compression of the lung parenchyma. So these patients with hepatopulmonary syndrome, they develop what is called platypnea. Right? What is platypnea? So platypnea is that the individual in sitting posture, they will have dyspnea. Right? They'll have dyspnea in sitting posture. But the same patient, whenever he lies down in supine position, the dyspnea will disappear. The dyspnea will disappear in supine posture. That is what is called as the platypnea. That is what is called as platypnea, right? Or we call it as platypnea orthodeoxia syndrome. Platypnea orthodeoxia syndrome, right? Now, in order to diagnose, okay, so in order to diagnose, one second, right? In order to diagnose this hepatopulmonary syndrome, what is the triad? There is a clinical triad. The triad of hepatopulmonary syndrome is that number 1, chronic liver disease, number 2, increased alveolo-arterial gradient while the patient is in breathing room air. Third one is there is intrapulmonary vascular dilatation. Right? There is intrapulmonary vascular dilatation. Okay, so this is a triad: chronic liver disease, increased alveolo-arterial gradient when the patient is in like room air, and intrapulmonary vascular dilatation. So this is a triad of the hepatopulmonary syndrome. Now the presentation will be platypnea orthodeoxia, right? And the diagnosis should be suspected. When will you consider hepatopulmonary syndrome? You will consider hepatopulmonary syndrome in a cirrhotic patient with pulse oximetry showing saturation less than 94%. When saturation is like less than 94% in a patient who is having cirrhosis, then you need to suspect the hepatopulmonary syndrome. Now, what is the investigation of choice, right? What is that which will confirm the diagnosis of the hepatopulmonary syndrome? The methodology by which you can confirm the hepatopulmonary syndrome is by doing an investigation called macro aggregated albumin lung perfusion scanning, right? So macro aggregated albumin, A stands for albumin lung perfusion scanning, that is MALP, macro aggregated albumin lung perfusion scanning, and this is more specific and may be used to confirm the diagnosis of hepatopulmonary syndrome. And the another important sensitive screening test. So what will be the screening test for hepatopulmonary syndrome? That will be contrast enhanced echocardiography, right? So that will be the screening test. What it will show you, that will detect the presence of pulmonary vascular dilatation, right? Your contrast enhanced echocardiography will detect the presence of pulmonary vascular dilatation. But what is that which will confirm the diagnosis? That is MALP, that is macro aggregated albumin lung perfusion scanning, right? Now what is the treatment in these patients? So as such, the prognosis is not good, right? These patients, they require long-term oxygen therapy. Long-term oxygen therapy, so treatment is long-term oxygen therapy, right? That is being advised. And this particular hepatopulmonary syndrome may reverse with liver transplantation. So when you do liver transplantation, that is the point when the hepatopulmonary syndrome can get reversed. Okay. So this is about your the complications in patients with the cirrhosis of liver, one of the very, very important area where the questions have been frequently asked in the hepatology, right? Next. So the next topic for the discussion now in the gastroenterology is the autoimmune hepatitis. So autoimmune hepatitis, as the word itself tells you, it is an antibody which is being formed against the liver. Now we have important forms of autoimmune hepatitis, that is type 1, type 2 and type 3 autoimmune hepatitis. So in all of these you have the characteristic, the autoantibody profile which is being present. So you take in case of the autoimmune hepatitis type 1, the characteristic autoantibody profile is the anti-nuclear antibody will be positive and as well as the smooth muscle antibody will be positive, SMA will be positive. Whereas in case of the type 2 autoimmune hepatitis, the characteristic autoantibody profile will be anti-LKM antibodies, right? That is liver, kidney, then microsome 1 antibody. So that is anti-LKM1 antibody. Then you take type 3 autoimmune hepatitis. Type 3 autoimmune hepatitis is that where the characteristic autoantibody profile is anti-SLA, right? That is anti-SLA. So anti-SLA, it stands for soluble liver antigen, right? And even your SMA, that is smooth muscle antibody, is also positive. So that is what is in case of type 3 autoimmune hepatitis, right? Next, so after having discussed about these three types of autoimmune hepatitis, now let me take up the other laboratory findings. So when you are using the word hepatitis, right, the important parameter is the enzyme, that is the serum aminotransferases, that is AST and ALT will be elevated more than 1000 units per liter, right? AST and ALT will be more than 1000 units per liter, and even the total bilirubin levels also will be elevated. So this is about your autoimmune hepatitis. And what is the treatment? So when you are using the word autoimmune, you should give the immunosuppressive agents, and that particular immunosuppressive agent that you need to give is the prednisolone, and this prednisolone should be given with or without azathioprine, right? This should be given along with or without the azathioprine. Okay, so this when you start this prednisolone with or without azathioprine, this will improve the symptoms of the individual. This will decrease the serum bilirubin, this will decrease the serum aminotransferase, this will decrease the gamma globulin levels. Okay, and not only that, this prednisolone will also reduce the hepatic inflammation as well. Now, so definitely yes, the very important group of drugs is prednisolone with or without the azathioprine. But in those individuals who are non-responders, in those individuals who are non-respondent, not responding to corticosteroids and azathioprine, you have given corticosteroids and azathioprine, but there is no response. So in these individuals with autoimmune hepatitis, the other alternative drugs that you need to try is you need to give the trial of cyclosporin or tacrolimus or right, or the sirolimus, right, or the everolimus. So these are the, or the other drug is methotrexate. The other drug is methotrexate. So these are the alternative drugs that you need to give if the patient does not respond to corticosteroid and as well as azathioprine. So this completes the discussion of your autoimmune hepatitis, right? So three types you have to remember: type 1, type 2, type 3, and that antibody profile is also very, very important. In case of type 1 autoimmune hepatitis, it is your anti-nuclear antibody and as well as the smooth muscle antibody. Whereas in case of type 2, it is anti-LKM1 antibody. Whereas type 3, you have anti-SLA and as well as the smooth muscle antibody, right? Now, then followed by that, you need to know about the viral hepatitis. So viral hepatitis, what is very, very important is like you have A, B, C, D, E. Out of which are very, very important for your exam is your B and as well as C. But anyways, I'll just give you a quick recap of all the forms, and in detail, I'll discuss about the B and as well as C. So you can just see this question. All these human hepatitis viruses are RNA viruses except. So which among this is not the RNA virus? That will be your the hepatitis B virus. So hepatitis B virus, it is the DNA virus. The remaining all the viral hepatitis virus except hepatitis B you have the RNA, right? You have the RNA. Next, and you have a new variant of, right? You have a new variant of the viral hepatitis that is called the hepatitis G. But this particular hepatitis G, it does not cause the human hepatitis, right? It has been found to show the hepatitis in the animals, but in humans, it does not cause the hepatitis, that is hepatitis G. Now, let us take up the discussion particularly on hepatitis B. Okay, or before going on to the hepatitis B in detail, let me just take up some of the single liner questions on all the forms of the hepatitis. So you see this question, the most common virus associated with transfusion associated hepatitis, the most common virus which is transfusion associated hepatitis will be the hepatitis B virus and as well as the hepatitis C virus, right? These are the most common viruses associated with transfusion associated viruses. And vaccine or prophylaxis is not available for which form of the viral hepatitis, that is hepatitis C virus, right? There is no vaccine or the prophylaxis which is available. And malignant potential among all these viral hepatitis, it is more common for hepatitis C virus, then followed by that the hepatitis B virus. And progression to chronicity is seen in case of the hepatitis B virus and as well as the hepatitis C virus, right? Progression to chronicity is seen in hepatitis B and hepatitis C virus. And perinatal transmission, right? Perinatal transmission is most significant for the hepatitis B virus. What is perinatal transmission? That is vertical transmission, mother to fetus. It is more common in case of hepatitis B. Whereas which are the forms of viral hepatitis which are being spread by the parenteral routes, that is your IV or subcutaneous or needle prick, that will be your B, C and as well as D. Whereas your hepatitis A and E, that will be non-parenteral route, right? What will be that non-parenteral route? That means they are being spread by the feco-oral route, right? They are being spread by feco-oral route. Which one? A and as well as E. Now, if you take the hepatitis B virus, it is not being transmitted through feco-oral route, right? It is not being transmitted through the fecal-oral route. And the most common hepatitis that progresses to chronicity, right? Remember, C for chronicity, C for hepatitis C, right? And most common cause of fulminant hepatitis in pregnant women, that will be the hepatitis E. And most common cause of epidemic and as well as sporadic hepatitis, both of them, it will be the hepatitis E. And the most common cause of sporadic hepatitis in children, that will be hepatitis A, right? That will be hepatitis A. Okay, so this is about the various forms of the hepatitis and important questions related to your viral hepatitis. Now let me take up detailed discussion related to the hepatitis B, right? Detailed discussion related to the hepatitis B. So if you take this question, that is the liver biopsy in acute hepatitis due to hepatitis B virus is likely to show all of the following except ballooning changes of the hepatocyte. Second option, ground glass hepatocytes. Third option, focal or spotty necrosis. Fourth option, acidophilic bodies. Right? Now, ballooning change of hepatocytes will definitely be there. Right? That is what is nothing but your ballooning degeneration. Then, coming to cytolysis, there will be necrosis of the hepatocytes. And there will be presence of acidophilic bodies, and these acidophilic bodies, they are called as the councilman bodies, right? They are called as the councilman bodies. Okay, so these particular councilman bodies are also seen, but the one which is not seen is the ground glass hepatocytes will not be there in patients with the acute hepatitis, right? Next, now if you move on to the other questions related to the viral hepatitis, yes, which of the following hepatitis virus has significant perinatal transmission? Just now we have discussed. That is, your hepatitis B has a very significant perinatal transmission. That is from mother to fetus. Now, next to this, you need to know about the serology. Or before going on to the serology, let me just give you a quick recap of the acute hepatitis and then we will move on to the chronic hepatitis. So, if you take this acute hepatitis, these patients, they have the prodromal symptoms. Right? What will be the prodromal symptoms? The prodromal symptoms in case of acute hepatitis will be anorexia, nausea, vomiting, fatigue, malaise, myalgia, fever. These are the prodromal symptoms, right? Fever, myalgia, fatigue, nausea and vomiting. So these are the clinical features. But on examination, what is that you will see in case of acute hepatitis is you will have that clinical jaundice, and even the urine also a dark urine, and the stool will be clay colored stool will be there. And because of this hepatitis, when you try to apply the pressure over the right hypochondrium, you will notice that there is tender hepatomegaly in the right upper quadrant. And in case of this acute hepatitis, the enzymes are elevated, right? The enzymes are elevated. Which enzymes? The ALT is more elevated than compared to that of AST in case of hepatitis. But whereas you take in case of alcoholic hepatitis, the pattern is exactly reverse. In case of alcoholic hepatitis, it is AST which is more elevated than compared to that of ALT. Whereas in case of acute viral hepatitis, it is ALT that is more elevated than compared to that of the AST, right? So this pattern is a very, very important question. And the other enzymes which are elevated in acute hepatitis is the alkaline phosphatase levels are elevated. But so alkaline phosphatase levels, they are elevated. But one point that you have to remember is that about the albumin. In case of acute hepatitis, the albumin levels, they remain normal because albumin, the half-life is up to 21 days. So the albumin level will not be reduced in case of the acute viral hepatitis. They are like usually normal. Okay, so these will be the features of the acute hepatitis. The jaundice, the icterus, what is the site where the icterus appears first? So when will the icterus appear? First of all, the icterus will appear when the serum bilirubin level is more than 2, and the icterus first disappears over the tongue frenulum. Over the tongue frenulum, you need to observe for that yellowishness, and followed by the tongue frenulum, you observe within the sclera. Why within the sclera? Because the elastin which is present in the sclera, it has a very good affinity for bilirubin. So that is the reason why jaundice is actually first detected by seeing the sclera. But actually the yellowishness, where exactly it appears first, that will be in the tongue frenulum. That will be in the tongue frenulum. Okay, right. So this is about your acute viral hepatitis. Now followed by this, and one more important thing in case of acute viral hepatitis that you need to know is the USG abdomen. So when you do a USG abdomen in case of acute viral hepatitis, there will be increase in the liver span, right? There will be increase in the liver span. And not only that, right? Not only that, the ultrasound liver will show a characteristic echo texture. What is that characteristic echo texture that can be seen in case of viral hepatitis is you will have the ultrasound showing the characteristic starry sky appearance, right? Showing starry sky appearance. But this particular point of starry sky appearance is not just seen in only viral hepatitis. This starry sky, you take where all you can get starry sky appearance, lymph node biopsy showing starry sky appearance. You can get this in Burkitt's lymphoma. Kidney biopsy showing starry sky appearance. You get this in case of post-streptococcal glomerulonephritis. CT head showing starry sky appearance. You get this in case of neurocysticercosis. Ultrasound abdomen of the liver showing starry sky appearance. That will be viral hepatitis. Okay, that will be viral hepatitis. Okay, right. So that was some points related to acute. But what is very, very important in the entire hepatitis, acute and chronic, serology is very, very important. Right? Serology is very, very important. Now, let me just tell you or discuss about the serology. Okay. So, role of serological markers in hepatitis B virus. So, you see this question. Early diagnosis of acute hepatitis B infection is made by presence of envelope antigen, presence of IgM anti-HBC in the serum, presence of surface antigen in the serum, presence of IgG anti-HBC in the serum. So what is that? It will tell you that it's an acute infection. Now, when you are having options like this, like you need to act little cleverly. So there is very high chance that you may go with the surface antigen, right? You may go with surface antigen. This is also a correct answer. But the best answer here will be the presence of IgM anti-HBC. Actually, in acute hepatitis, you get this both. Surface antigen will be positive and IgM anti-HBC also will be positive. But why is that we don't go with surface antigen is that because the surface antigen is also positive in case of the chronic hepatitis. Surface antigen is also positive in carriers. Right? Surface antigen is also positive in carriers. Okay. So that is about the story of the surface antigen, in which all conditions it will be positive. Then what about the anti-HBs? The another important serological marker is the anti-HBs. If anti-HBs is positive, that indicates the development of immunity, right? That indicates the development of immunity. That means the individual is immune. The individual is like cured of the hepatitis B infection, or the individual has no active disease, right? The individual has no active disease. So that is what is your the presence of anti-HBs AG tells you. Now, what about the other serology in the options which has been given to you? The presence of IgG anti-HBC, that tells you that the patient is having chronic hepatitis. And what about the presence of the envelope antigen? See, the presence of envelope antigen, that is HBeAg, that tells you that the individual is having higher infectivity with hepatitis B virus, right? The individual is having higher infectivity with hepatitis B virus. Okay, so the presence of envelope antigen. So infectivity, if you see this question, right? So hepatitis B infectivity is indicated by, right, anti-HBs AG, surface antigen plus envelope antigen, anti-HBs plus anti-HBC, anti-HBe plus anti-HBs. So that is the presence of HBs and envelope antigen tells that the individual is having, the individual is like highly infective. That means the virus is like replicating. The virus is like replicating. That is what is the importance of the envelope antigen. The next question you see here, a 30-year man presented with nausea, fever and jaundice of 5 days duration. The biochemical test revealed the bilirubin of 6.7 milligrams per deciliter, SGOT, SGPT 1230 and 900 international units per ml. The serological test shows the presence of surface antigen, IgM anti-HBC and envelope antigen. So what is the most likely diagnosis in this question? So the options are chronic hepatitis B infection with high infectivity, chronic acute hepatitis B with high infectivity, chronic hepatitis B with low infectivity and acute hepatitis B with low infectivity. So you are having the presence of IgM anti-HBC. That means it is acute hepatitis. And next to that, the individual is having the envelope antigen. That tells the individual is having acute hepatitis with high infectivity, right? Acute hepatitis with high infectivity. And one more important serological markers that are being asked previously is about the replication. So, right, the presence of the replication. So, what are the markers of the HBV replication? The markers of the HBV replication, we have two important types of markers. Like we have a qualitative marker and we have the quantitative marker. So, you take the qualitative marker. The qualitative marker will be the envelope antigen, right? The qualitative marker will be the envelope antigen, whereas you take the quantitative marker. The quantitative marker will be HBV DNA and DNA polymerase, right? The quantitative marker will be HBV DNA and as well as DNA polymerase. Out of all these, which is the definitive marker of viral replication? The definitive marker of the viral replication is the DNA polymerase. So DNA polymerase is a definitive marker of the viral replication, and these three are the markers of the HBV replication: HBV DNA, DNA polymerase and envelope antigen. Envelope antigen, it is a qualitative marker. And once we are done with the, okay, and some more points, right? IgM anti-HBC, what is this? Acute hepatitis. HBsAg and IgM anti-HBsAg. Sorry, HBsAg plus and IgM anti-HBsAg is positive. So what does that tells you? See, the presence of HBsAg and as well as the IgM anti-HBc antigen, this again tells you the same thing, that is acute viral hepatitis, right? Acute viral hepatitis. And this IgM anti-HBc, either it tells you acute hepatitis or it tells you that the individual is in window period, right? Or it will tell you that the individual is in window period. And along with surface antigen, if there is IgG, that tells it is chronic hepatitis. And if there is anti-HBsAg, that tells that the individual is like vaccinated or the individual is like immune or the individual is like cured of the disease. Okay, right. So this is about the serological markers, which is very important question in the hepatitis B. Now the next important thing is related to the treatment. Next important thing is related to treatment. But before that, there is one question which has been asked previously related to the gene. Related to the gene. Reverse transcriptase of hepatitis B virus is coded on the following gene: C gene, S gene, P gene, X gene. Remember, it is the P gene which is the largest gene. This P gene is the one which codes for DNA polymerase. Right, this codes for DNA polymerase. Okay, so the enzyme DNA polymerase, it has both DNA dependent DNA polymerase activity and RNA dependent reverse transcriptase activity. So that is about the story of the reverse transcriptase of the hepatitis B virus is coded on the following gene, that is the P gene. Now you see the questions related to the treatment. Which one of the following pairs, right, which one of the following pair is not correct regarding the hepatitis B management? Supportive, supportive care, acute viral hepatitis B, antiviral drug, chronic viral hepatitis B, supportive care, chronic viral hepatitis B, antiviral drugs, acute viral hepatitis B. So remember, in case of acute viral hepatitis, there is no role of antiviral drugs, right? There is no role of antiviral drugs in case of acute viral hepatitis B, right? In acute viral hepatitis B, it is only just supportive care. We don't give antiviral drugs. But whereas in chronic hepatitis, we give both antiviral and as well as the supportive care both. Okay. Whereas in acute, it is only supportive treatment, symptomatic treatment. There is no role of the antiviral drugs, right? Next, then you take the treatment of chronic HBV infection. So which are all the drugs which are given in the treatment of the chronic HBV infection? So we have almost a list of around 6 to 7 drugs. Among the options which has been given to you, interferon is the answer, adifovir is the answer, lamivudine is also answer. This famciclovir, ganciclovir we don't give for HBV. So what are all the drugs we give for the hepatitis B infection? One is your interferon, the other one is lamivudine, third one is adifovir, next is entecavir, then telbivudine, then tenofovir. So these are the drugs which are given for chronic HBV infection, right? But out of all these, which are the first line drugs? Out of all these, the first line drugs will be PET. What does this PET stands for? Pegylated interferon, then entecavir, then tenofovir. So these are the drugs which are first line for the treatment of the viral hepatitis, right? Next, then when is that you need to start the antiviral drugs for chronic hepatitis is the next important question. So you see this clinical scenario. A young man presents with the surface antigen positive, then anti-HBC IgG positive, envelope antigen negative, normal levels of AST and ALT, asymptomatic. What is the next line of management in this patient? Wait and watch, lamivudine, immunoglobulin, liver transplantation. So here the answer is wait and watch. You need not start the antiviral drug, that is lamivudine. Why is that you need to just wait and watch in this individual, and what is the indication to start the antiviral drugs? See, the indication to start the antiviral drugs is that you need, see, if surface antigen is positive, it doesn't mean that you need to start the antiviral drugs, right? Or if IgG anti-HBC is positive, that means it is chronic hepatitis. That doesn't mean that you need to start the antiviral drugs. You need to check for the HBV DNA levels before starting the antiviral drugs, and you also need to check the HBeAg levels. HBeAg tells you what? That is the infectivity. It tells you about the infectivity. Okay. So if HBeAg is positive and if HBV DNA levels, this is the latest data what I am telling you. Latest data is that if the value of your HBV DNA levels, if it is more than or equal to 2 into 10 to the power of 4 international units DNA per ml, that is the point when, right, that is the point when you need to give, that is the point when you need to start the antiviral drugs. Okay, this is the latest data. But here if you see, like envelope antigen is negative. That means what? Envelope antigen is negative means low infectivity. And AST and ALT is normal. That means there is no hepatitis, right? There is no severe form of hepatitis. So that is the reason why in this patient you need not start the antiviral drugs. You just need to wait and watch, and then you need to monitor the HBV DNA levels, AST and ALT levels. Okay, right. So that was about your hepatitis B. Now the next important thing in the GAT is the hepatitis C. That is viral hepatitis C. So now if you take the hepatitis C virus, that is the most common virus which is associated with transfusion associated hepatitis. Okay, so this is being transmitted most commonly via transfusion. Okay, so the most common, and the other method is by the percutaneous route. So basically what I mean to tell is the parenteral routes, right? Parenteral routes. And remember, your hepatitis C is not spread through fecal-oral route. Is not spread through the fecal-oral route. And for this hepatitis C, there is no vaccine or prophylaxis which is being available. And this hepatitis C virus, if you see, it is the one which has the highest malignant potential. Malignant potential is highest for the hepatitis C virus, right? And also in hepatitis B. Now, if you take the antibodies in hepatitis C virus, the antibodies are anti-LKM antibodies. The antibodies are anti-LKM antibodies, right? So the LKM stands for what? The LKM antibody, they stands for antibodies against liver, kidney, microsome, right? Antibodies against liver, kidney and microsome. That is what is your the anti-LKM antibodies, right? And these anti-LKM antibodies are detected in the sera of the patient, and these antibodies, they act against what? These antibodies are targeted against cytochrome P450 component, right? It is targeted against, right? It is targeted against cytochrome P450 component. That is very, very important, right? Which is the second messenger. Now, what type of LKM antibodies you have in case of hepatitis C? See, anti-LKM antibodies, you have anti-LKM 1, 2, 3. The type of anti-LKM antibodies that you will have in hepatitis C is the anti-LKM 1. What about the others? You take the anti-LKM 2. Anti-LKM 2 is seen in case of drug-induced hepatitis. Right? In drug-induced hepatitis, you get this anti-LKM 2. Whereas, you take anti-LKM 3. Anti-LKM 3, it is positive in case of chronic hepatitis D. Right? In chronic hepatitis D, you have this anti-LKM 3. Right? So, that is about the antibodies. Now, let me tell you, in these patients with hepatitis C, it is not just only, right, the hepatic manifestations. There are extra hepatic manifestations in hepatitis C. What are these extra hepatic manifestations in hepatitis C? It can cause abnormality within the blood. That means it can cause agranulocytosis. It can also cause aplastic anemia. It can also cause thrombocytopenia, right? So aplastic anemia, thrombocytopenia and agranulocytosis, right? And other extra hepatic manifestations are, it can also cause diabetes mellitus, that is type 1 diabetes mellitus. And there can be also neurological manifestations, that is development of the Guillain-Barré syndrome, right? Development of Guillain-Barré syndrome, okay? And other malignancies like non-Hodgkin's lymphoma. These are all the one which can be caused by the hepatitis C virus. And even cryoglobulinemia. For the development of cryoglobulinic vasculitis, what is required is the hepatitis C is being required. So apart from these antibodies, what is the further workup which is required? Right? Definitely yes, anti-LKM1 antibodies are there. It is HCV infection, done. The next thing is you have to check for the HCV RNA levels. Once you find that there is detectable levels of the HCV RNA, that tells the patient is having chronic hepatitis C. For suppose, if the patient is not having, that means there is no detectable HCV RNA levels. If there is no detectable levels of the HCV RNA, then you need to consider it is not chronic hepatitis. Right? It is not chronic hepatitis. Okay. Then what is the indication for treatment of your viral hepatitis? The indication for treatment is that after checking the anti-LKM antibodies, after finding that there is significant levels of your HCV RNA levels, then you have to check the ALT levels. Right? If the ALT levels are elevated more than 2 to 3 times, that is the point when you need to start the antiviral drugs. That is the point when you need to start the antiviral drugs. For suppose there is like detectable HCV RNA, we are considering it as chronic, but there is like normal ALT levels. When there is normal ALT levels, whether to start treatment or not, that will be decided by doing the liver biopsy. Right? That will be decided by doing liver biopsy. Right? So perform the liver biopsy to obtain the histopathological diagnosis and staging of the chronic hepatitis. And in the liver biopsy, if it shows that there is chronic hepatitis, then you start the antiviral drugs. Now, what are the antiviral drugs that you give in case of the chronic hepatitis? So, this hepatitis, you have like genotype 1, you have genotype 2. So, for genotype 1, the drug of choice will be ledipsavir. Right? For genotype 1, the drug of choice will be ledipsavir. And for genotype 2, the drug of choice will be sofosbuvir, and the other drug will be ribavirin. Right? The other drug will be ribavirin. Okay. So these are the treatment options for genotype 2. And you should know the prognosis also. So which particular type of hepatitis C virus has sustained, that means good response? The one which has reduced responsiveness. See, genotype 1, it has reduced responsiveness. But whereas genotype 2, it has sustained responsiveness. Right? Sustained responsiveness. So if the individual is being infected with genotype 1, the prognosis will be bad. Right? The prognosis will be bad. And the other points to tell that the prognosis will be bad in hepatitis C virus is that one is your genotype 1. And second is, if there is high levels of HCV RNA, worst prognosis. Advanced fibrosis on the histology, worst prognosis. Right? And there is long duration of the disease of your hepatitis C, then also the prognosis is bad. Age of the individual more than 40 years, then also the prognosis is bad. The patient is like immunosuppressed, then also the prognosis is bad in case of hepatitis C. The individual is like obese, the prognosis is bad. Okay. So, and if the adherence is not good, then also the prognosis is bad. And males, they have bad prognosis than compared to that of females. Right? Males, they have reduced responsiveness to your antiviral drugs than compared to that of females. Females, they have sustained responsiveness for your chronic hepatitis C treatment. Okay. So this is about the hepatitis C. So with this, we are done with the GAT rapid revision. Right? So in the GAT, like what all topics we have discussed is mainly the cirrhosis of liver and as well as the complications of cirrhosis of liver. And the next important thing in the GAT is the hepatology, right? That is your viral hepatitis. See, majority of your GAT, like you will be read in the surgery. So which I am not going into your peptic ulcer disease or malignancy, stomach carcinoma and all. What is very important in medicine, right? I have tried to discuss that. Okay. So with this, we'll try to wind up this particular session now, right? So two more topics, that is infectious diseases and hematology is there. I will try to make out one more day, right? It is not tomorrow. I'll try to make out one more day to discuss infectious diseases and as well as hematology. Actually, infectious diseases is a topic of your microbiology, but what we discuss in medicine is treatment only. And even hematology, it's a topic of pathology, right? What we discuss in here is only the treatment in hematology. So these two topics, I'll try to make out one more day before your exams, and I'll try to do a quick revision of the infectious diseases and as well as hematology subsequent.